Tracy, I just sent you the Zoom link.
Okay. Wait on it to come through. All right, it's posted. Let me go verify it's working. Yes, we're good to go.
Thank you.
You're welcome.
Okay.
Dr. Borland, we are good to go. You are live on YouTube. You can start your meeting.
Okay, so I can open.
The host
Correct.
has been notified about your arrival. Your conference will begin momentarily. Please continue to hold.
Christine, is that you?
We need to know who is CS 0909.
That's Christine, I think. Yeah.
Well, we need to hear it from her.
Just a second, she just responded to me, sent me a message.
It's telling me that the host has it locked, but the host has been notified. That's what Christine just texted me.
Christine, can you hear us? We hear your background.
The host has been notified about your arrival. Your conference will begin momentarily. Please continue to hold.
I don't have anything coming in that she's trying to get into the meeting.
She's in the meeting. Technically, I can hear us talk. I wonder if she's got her microphone and speaker set properly.
I think she's on a phone.
Well, she probably ought to take it off of speakerphone and put it right to her ear. I don't know if she can hear us saying that.
She said she could, when I spoke with her earlier, she said she could see everybody, but she couldn't hear. There she is. Okay.
Now, if she's on the phone and not a computer, she will not be able to go into executive session with us.
Okay.
That is the one limitation that phone people cannot go into executive session. They have to be by internet on a computer or a similar device.
Christine, can you hear us?
All right, let me ask a hard question. Do we have a quorum without Christine?
I think so.
It's showing 13 participants.
Yeah, you have 6 without Christine.
All right, well, we should try and see if we can make Christine work, but we can conduct business, correct me, Lauren, under the new rules, if I'm saying them wrong.
Yeah, as long as there's a quorum.
Okay, so we have a quorum. Unfortunately, Christine is not working well, and I don't think it's her end. I think it's, I don't know whose end it is, but it doesn't seem to be ours. So we can go ahead and convene the meeting. Joseph, go ahead and you can get started, and hopefully Christine can figure it out as the meeting goes along.
Okay, one call to order the meeting of the Polysomnography Advisory Committee. Please note, any comments by the public are welcome and can be emailed to public comment at lsbme.la.gov. Please confirm that you verified the identity of all tele and video conference participants.
We have verified all of those, sir.
So all additions to the executive or public agenda must be made presently. We will no longer make any additions to the agenda after the close of the public session. Next, let's go to the roll call. I'm Joseph Bordelon. Can everybody identify themselves with the members?
Kylie Foster.
Kyle Schwab.
Lauren Davis.
Judson Willard.
Joshua Johnson.
And from the staff, we have Lauren Studdeth on one of our new attorneys, Ms. Wilton, Ms. Bartholomew, and of course, Olivia, who's coordinating with me.
Good morning.
Good morning. Okay, first agenda, if we could have the minutes of the previous meeting, they're attached at the bottom of your agenda that was sent out.
Dr. Claudia, you can share your
Thank you,
screen.
ma'am.
You're welcome.
And I'm showing them on the screen right now. You should be able to see them. Let's see if I can make it a little bit bigger. And maybe go a little bit more. Can everybody read that?
Any questions or comments on the minutes? Do we have a motion to accept them?
I motion to accept them.
The host has been notified about your arrival. Your conference will begin momentarily. Please continue to hold.
All in favor?
Aye.
Aye. Any
Aye.
opposed? Any opposed? The minutes are accepted. Under old business, I requested we bring up the rules and regs to see if there were any concerns or comments or items that we needed to be aware of. I think that when we last discussed this, we have to renew or have the present rules renewed in 3 months. Is that correct, Ms. Wilson?
Yes, yes.
The emergency rules have to be renewed and changed.
Do we need to do anything with that ourselves, or will that happen independent of us?
We'll take care of it. And in the meantime, we'll also go through the process of making a permanent rule so that going forward, it will work that way.
Okay. Anybody has any comments or about the rules that are out there or concerns? And I guess, have we had anybody request the new pathways or come through the new pathways?
Ms. Bartholomew might be able to answer that. I know of none at this time, but she probably has better knowledge of that than I'd have.
We did have someone call and ask about it, but that was it. He did not submit anything as far as a step. He just asked.
Okay.
I did tell him it was in the works, but that I did not have all of the okay yet.
Okay. So the other issue was the polysomnography course with Miss Allen. Kylie and I had a Zoom meeting with her, and she's working on basically some questions that would be asked of new registrants. And she, I think, had other conflicts and what is not able to be with us today. But we just wanted y'all to know that that is in process of progressing along. Kylie, any other comments on that?
No, I don't have any.
Okay. The other issues are the role of patient educator. I think Lauren Davis received some input or request from ASM about this, and she can make some comments for us.
I'm sorry, you were talking to me?
Yeah, about patient educator.
Okay. Yeah, I looked into it. The BRPT sponsors us a sleep educator exam. The requirements to sit for the exam seem to be very high bar. They have a baccalaureate degree or 1,000 hours of clinical education. I just talked to Dr. Connolly, who's been utilizing a sleep educator in his practice, and finds it very helpful. It basically is a clinical billing, the usual clinical billing that we use as providers. I think the questions that come up, or my feeling about it at this point, is that I think it probably needs to be a separate licensure. So I would like to have them perhaps explore having a separate license that's for a sleep educator. I think we have to be careful on what we're allowing the sleep educator to do. We're going to have a discussion on probably on two fronts. Do we allow them to set patients up on home sleep testing? And do we allow them to do work with the CPAP and BiPAP machines? Because I think we have to look at, how much does it overlap with our regular sleep tech licensure and the Respiratory Care Act. But if they use them just as clinical, educators to expand, education, like the physician would come up with a plan, we're going to do, cognitive behavioral therapy for insomnia, and then would hand the patient over to the sleep educator to do that. So if it's just an educational kind of clinical licensure, I think it would be really helpful.
Can I ask, do you think that these people should be setting up sleep studies and adjusting CPAPs?
Well, I think that's a discussion that we have to have and decide on. I think that as far as setting up CPAPs, I think there's going to be some problems with the Respiratory Care Act. And then if we're going to have them do home sleep testing, we have to decide if we're comfortable with that, or, to have that discussion.
All right, well, let me say to you that in creating a new class of license, we have to modify the Practice Act for polysomnographic technicians. So the key is it's going to have to change no matter what. What we need to know is, what is the advisory committee recommending for the guardrails, if you will, the limits of what they can and should do and what they should and should not do. And you need to give that to us. I mean, bullet points are fine. We don't have to have any, fancy language. We got Miss Wilton and Miss Lauren who will happily put it in the proper language. But again, the key is we need to know what you recommend, then we have to get the board to approve it, to create the class and that kind of stuff. But again, the board's going to want to understand, what are they doing, and are we protecting the public by what we're doing, and that kind of stuff.
Yeah, I think some of the things may have to be under direct supervision of a physician. That would be, one way to work that. If you want them to do specific things, should we look at it as, they can see patients independently under clinical codes, but if they're going to do CPAP or BiPAP setups, or they're going to set up home sleep testing, do we want to have that under, in an office where there's actually a physician present? That there are a lot of ways to skin this cat and look at it. I can dig a little deeper into exactly what the curriculum is with the sleep educator and see if we think that it's adequate education for those two aspects, the home sleep testing and the DME portion of it. And I can kind of get back to you on that. I think as far as the clinical education portion, I think it's pretty a no-brainer that we should have a licensure allowed them to do that. I think the sticky things are the home testing and the DME.
Well, let's do this. Why don't you and I work together? And you and I can get together and talk about what you want, what you're going to propose. And then at the next meeting, we can put together the list of what we think they should do and shouldn't do. And then if the advisory committee recommends that to the board, we'll get it going. So if you're willing to work with me, Lauren, I'm happy to do it.
Love to.
What does the LCD coverage say about home sleep studies and who can set them up?
Right now, it says that you have to be a licensed respiratory technologist. Either a respiratory technologist or a polysomnographic technician with the permissions to do it. So you have to have something to be able to do that. And again, I want to comment, if it's just to do education, that's one thing. If they're going to be doing something else, we're going to have to really figure out how to get them in under the Practice Act to be qualified to do it, or change the Practice Act.
Is this supposed to be like an advanced practitioner, like a nurse practitioner or a physician assistant?
I don't know enough about it to say.
This is
very similar.
It's the clinical sleep health educator certification, correct?
Yes.
Okay. I'm familiar with that.
Yeah, it's the same billing codes as a mid-level provider or a physician. It's a clinical code.
Yeah, I always read it kind of like a nurse practitioner, that you could go and help in clinics with doctor
Exactly.
oversight.
Yeah.
Well, I would be very careful in using the term like APRNs, because that's a whole separate class of license that we have no control over, and I would not want to get in that bag of worms because it would create. So I don't want to use that language ever again if we could avoid it.
Yeah. That's good.
Next item, the Inspire procedure. We received a note from TAC Perulian requesting that we add the Inspire procedure and follow up to the scope of practice for RPSGT. And so we kind of wanted to discuss it. I kind of felt more like this should be handled by the individual institutions rather than making everybody that gets licensed have this in their scope of practice.
Well, Joe, first of all, when you say request from the board to address the stimulator procedure, is he asking that you all are going to be doing the procedure? Because man, I don't think that's a no. That's a negative. Doctors, basically only ENTs who know enough their way around the recurrent laryngeal nerve and everything else should be the ones doing this procedure.
Well, no, I think it was for them to participate in the procedure where they would be helping the doctor adjusting the equipment and then following up afterwards.
Well, correct me if I'm wrong. I apologize. Excuse me, Dr. Davis. There's a surgical procedure in the operating room, and I'm not sure our respiratory polysomnographic technicians or respiratory therapy technicians are qualified to act as surgical assistants. Is that what we're suggesting? Or is it just the adjustment of the stimulator after it's in place and functioning?
After it's in place and in function, I would think.
We're already actually, I hate to bring this up, but we're already doing that. So we're not in the sleep techs are not in the OR for placement. That is done by the surgeon, and at least in our community, we have 3 surgeons doing it. We've done them for 2 to 3 years now. I just went in for one of the procedures last week. I've seen the DICE procedure and the Inspire procedure. What would make sense, and I think what they're requesting, is that the surgeon and the Inspire representative are in the OR. They do all the work in the OR. Then the patient, after they're discharged, they're followed up at about 4 weeks with the surgeon to look at the surgical sites, tongue activity, all that stuff, and then activate the Inspire. What we've done in our community is then the patient comes back to me. I have the Inspire rep in the clinic whenever an Inspire patient is there to make adjustments. But what we need to adjust for the technology for our act is that those patients somewhere at 6 weeks after activation or beyond are coming in for sleep studies with the Inspire, and the technician is going to be turning on the Inspire, adjusting the Inspire, some education, and then, setting settings as they go back out again. And so we need to have that interact because we're doing that as we speak. Now, I will tell you that Inspire has a certification program. Both of our night techs that do the Inspire titrations have been certified with Inspire. And so that may be an avenue to get Inspire certification, at least for this specific hypoglossal nerve stimulator. I'm sure there are going to be other ones, and we'll have to address that when it comes down the road. But for now, Inspire has a certification process.
That sounds like we can probably do that under the rules, because it's just a new procedure that's being done by our existing technologists and technicians that are trained to do it. And we just have to say, what's the permission? What's the requirement? I think you can keep that in the rules and not change the Practice Act. But again, Pat and Lauren and I are going to have to look at that and make it work for you. But I need to understand, right now, today, there are very few people, maybe the high level, certainly all the cardiologists may adjust a pacemaker. Some of the PAs and APRNs that are high level trained and certified to do that can do it. But and then under the clinical practice guidelines that they have with their supervising physician or a collaborative practice physician, do you want to do something like that for adjustment to have some sort of specialized requirement, or do you think it should be just part of the normal training?
You mean, should we be training all of our techs how to act, how to turn on and adjust and Inspire?
Well, you're going to have, is it going to be something that's part of the curriculum that they're getting and they're coming out, and all we're going to have to do is have an interim period of certification course training that we have to say before the people who already finished school can do it? Okay, it's just kind of like it's just like a surgeon that learns a new procedure. He may not have learned laparoscopy in his residency if you're an old guy like me. They learned it, they took the course, they did it, and then they got the privilege. We want to handle it as something that now all of our surgeons are doing laparoscopy in their training. So you had to make adjustments, hospitals made adjustments, and we'll have to make adjustments. Unless you want to say that this is only something that can be done, and you'd have to set up a collaborative practice agreement and all that kind of supervision requirements. You got to tell us what you want, but we'll tell you what's bad and good about each thing you ask us.
How about we do an interim 1-year thing where we require Inspire certification for titration nights until we kind of get our feet on the ground and see what this is going to be. They need some training in order to do it. And so,
do you think this is more or less dangerous? Is it as dangerous as adjusting a pacemaker?
Not at all. The only thing you're going to do is disrupt somebody's sleep.
Okay. Well, as we talk about the other issue, maybe you and I can draw the parameters, the points that they want to do, and we can talk about the rule changes to adjust that, because I think it's probably better to keep that in the rules. The other, and creating a new license class, is entirely different.
Yeah. Kylie was sent a text that TAC was requesting to make a comment. Is that possible?
Okay, hold on a minute. I don't have any comments in public comments. You can send it to us directly.
But he said he was on the meeting, but he's muted. I'm not really sure.
Hang on, let me see if he's on the meeting.
But Delgado is teaching their student about Inspire.
Yeah, and that's what I'm thinking. There's going to be a group of people that never learned it, but will learn it very shortly. Is coming out, and we can just adjust the rules for that. But I do not see them and him on the meeting itself. He may be watching the YouTube, and his comment can come by public comment.
Is that the person that reached out to Josh?
No, that's a different person.
Okay.
But I'll tell Tosh to email the public comment
Please,
email.
Yeah.
because he's not on our Zoom. I can tell you that.
So I'll mention again, it's public comment at lsbme.la.gov.
Yes, Victoria, and this is Darby. We're the Spencer sisters. We're not sisters.
Great. Alice, told me you're an expert.
Solving.
Well,
So my question again is, do we need to change the rules, or can we leave the rules as written accommodate for this right now?
No, I think you're going to have to change the rule. But there's two ways to do it. One is change the rule at one time, or issue another emergency rule to include that. But again, the real thing is we can't even decide that until you all decide what are the guidelines for it to do, what are the requirements to be able to do it. I mean, is it just if it's being taught in school, the people that are coming out are going to get it, but the people who have not been taught about it, how they're going to be certified to do it. And all of those things need to be addressed as we change the rule, and how we change the rule will be determined by what you all tell us.
I think the thing that makes a sense is have a 1-year interim rule where they have to have certification through Inspire to do adjustment during titration. They shouldn't be doing the activation. It should be done by the ENT. They should have nothing to do with the OR or inserting it. But when they come in for the titration night, they need to have some training, and all our techs out there need to be trained in some way. We don't have any other way to do it right now. The Inspire is offering the certification, and I think we're going to have to utilize it.
Okay, I heard you refer to another system that's out there as well. So if you just limit this to Inspire, you would eliminate the other system. Are both of these systems similar enough that we could say any hypoglossal nerve stimulator device can be titrated?
I'm not aware of any that are being done in the state. I know there's things coming through the FDA. There are things that are in Europe. There's bilateral hypoglossal nerve stimulator. We could probably get by with just the Inspire unless somebody else knows of another hypoglossal nerve stimulator that people are putting in, but I'm not aware of any other one.
In our rules, we say that we can do titrations of oral devices, don't we?
Yeah, but that's not an oral device.
But
and how are you, again, you've not, in other words, right now the devices you all are titrating are the PAPs and the CPAPs and the BiPAPs and that kind of stuff. And that's not a problem because everybody's trained on it. But let's say you have a tech that trained 2 years ago and just is in and out, is active, has not taken the Inspire training and wants to adjust that machine. Is there a danger to the public by letting him do that? Or do that?
Yeah.
And if it is, then we got to figure out a way to address it in the rules. And I think if what I hear you saying is have an emergency rule that we agree to automatically adjust every 180 days. I don't know how many times we can do that. Ms. Wilton can answer that. But we probably have to have, I don't know if we can have a 1-year rule, but Ms. Wilton, you have to tell us about that.
No, you can only re-up an emergency rule twice. You can have a total of 180 days. So you have to, and they're presuming that you need to get your permanent rule in place within that a subsequent 6 months after your first emergency rule.
Can we make it a permanent rule from the get-go? It seems like reasonable that the tech would do some sort of certification, and then that would either you learn it in school, or if you hadn't learned it in school, you have to be certified.
And that's fine with us too. I mean, but the key is, we have to make it generic enough if as they add new machines, because you don't want to change the rule every time they add a new device.
Mhm. You
Well, I
might
guess it's like you
say
said, we're
for-
going to assume people are going to learn this, clinically, that, the people that are out now will be learning it without the certification eventually.
Right, but there's just two classes of people, and you're gonna have to put basically an ability for people who need to be trained and people who are getting trained as part of their education. And then you can sunset the rule in time, but the key issue is you have a whole cadre of techs out there that if they want to do it, we have to do it, it takes to protect the public. And as I asked the question before, is the titration dangerous enough that we need to have some rule to protect the public? If you
I'd say no. My feeling is it's not dangerous, and we could talk about that more. It sounds like Dr. Davis, you don't think it's dangerous either. It's not sending any electricity anywhere other than to the tongue, and there's a limited amount of voltage the tech is allowed to manipulate. So you can only go up or down up to 1 volt. And I would say it's not dangerous unless you could go several volts. It's not dangerous to your heart. It's more, could you overstimulate the tongue? But I've had a lot of experience with them, and I don't think it's dangerous, but I think it's reasonable to require a certification if that's easily attained.
In the interim, does the individual institutions provide an access or a procedure where they can approve this?
What, you mean hospitals or
Yeah.
schools?
Yeah.
Well, hospitals are they're not only gonna let people do it that they're credentialed to do it. So that's none of our business, okay? I understand that we're talking about after the procedure is done and the patient is seen in a clinical setting that may or may not be supervised by a physician. And the key here is, do we want them to independently be able to adjust these stimulators, hypoglossal nerve stimulators? And I think the key is we can set parameters, we can make, but you have to tell us, and Ms. Wilton will put it in the proper language to make it a rule, and we can do that. But the key is, we want to make sure that whatever we decide is in the best interest of protecting the public.
Well,
I
how
still
about
have
instead
that.
of using, if the concern, if we want to make a regular amendment that's just going to be there forever, maybe what we could do is, rather than, ever using the word inspire, just stick with hypoglossal nerve stimulator and then require a certain amount of hours of training. And so it can be done by anything, so an accredited lab could set up a training program on how to adjust the hypoglossal nerve stimulator they're using locally, or you could get the Inspire credential, or you could get whatever company comes down the road, maybe just specify a certain amount of hours of training on the device.
I think that's reasonable. And again, if you would like to, you and I put those bullet points together, maybe you and I and Kyle can get together, put the bullet points together, present them to the whole committee next time for approval. And then Ms. Pat can start talking about an emergency rule or a rule modification.
Yeah, we can do that. And the only thing is, if you're going to be general, and I'll say the word vague, not in any bad way, but sort of vague, and leave yourself a lot of wiggle room, it may be that different devices require different amounts of training. I mean, I don't know. So you might want to, you might want to leave yourself room to decide that a certain type of device that may come down the pipe requires X number of hours, and a different one requires it. But we'll massage all that language to your satisfaction. But I'm just throwing that out there as you make your decision on giving us a template of what you want us to turn into a rule.
So again, just to make it clear, where I think we should be going is, if Miss Olivia will set up a Zoom for Lauren and Kyle to get together with I and possibly Miss Wilton, and we'll put together the bullet points for both the new license class as a sleep educator and the new procedure titration, and then we'll present it at the next meeting, if that's okay with everybody.
Sounds good.
Yeah, that's not a terribly difficult undertaking. We should be able to accomplish that fairly rapidly once it's approved.
Okay.
I still don't have any public comments, sir.
Okay. Can we go to the next item?
Let's see. Yes, sir.
Home sleep studies.
Okay, well, okay.
Uh,
Sleep studies.
So we've kind of discussed home sleep studies on and off. We had we kind of ran into a brick wall, I think, when we tried to work through the DMEs, and so I think the last time we discussed it, we wanted to see if any states had ways of handling it, possibly requirements of the referring provider or the ordering provider to do the follow-ups. And since the last discussion, I think Dr. Swab has received or communicated with us that he was kind of getting overwhelmed with patients coming in that had not received their follow-ups after receiving a home study and an interpretation by another sleep doc. And this was Matt Abraham, who has a contract apparently with the cardiology group to provide interps and follow-ups. I did get in touch with Matt, and he sent me some information which I asked y'all to include. You're seeing there a letter that we've had in place for the past, suggesting that individuals needed to have the test applied by a licensed individual and not sent to them in the mail.
Yeah, I was not able to find any regulations or laws in different states that address this question directly. I am concerned, obviously, we've talked about before, with the potential commerce and antitrust, anti-competition type regulations from a company sending these things out. I think we would be hard pressed to interfere with that level of commercial activity. I think that we could potentially propose, if we can make a good enough case, that it's essential for the protection of the public and safety and so forth, for these that are related to, I mean, maybe we even break it down by diagnoses or something. I don't know, because it almost looks like some of these mail order companies, it's like it's like people who buy their own diabetic glucose meters and that kind of stuff, that no physician is involved in any way, shape, or form. So I think it's a legitimate concern that we put some guardrails on what happens after it's delivered and who can interact with the consumer/patient about results and interpretations and so forth. But I don't think we can just outright, I don't think this letter is probably consistent with the current state of the law.
That's an advisory opinion.
Yeah, that's what
I was wondering if somebody orders a test for a patient, they're responsible to inform the patient of the results. And just like if you order mammograms or other tests that you have to inform them of other results. Just, you know,
I think it's on a scale, frankly. And like I said, I think maybe there's like a home glucose meter on one end that an individual can buy without any kind of prescription or anything. They can just buy it off the shelf versus a mammogram, which nobody's doing a home mammogram. You know, I mean, it's a scale.
Yeah.
And Joe, if I may interject, there's a federal law that's been around for about 15 years now that mammograms have to be sent to the patient by the radiographer with their interpretation as well. I'm not sure if you want to do this like mammograms and get into that.
I definitely think there can be a valid, absolutely 100% valid rule enacted that requires physician involvement, local physician involvement, or quite frankly, maybe even telemedicine involvement. I don't know, but I think you can protect the process by having a physician involved some kind of way, but I don't think we can stop the direct sale, is what I'm saying.
The one thing that I'm running into, so some of the cardiology groups that distribute this equipment to do the home sleep tests use LPNs to do that, which I think is reasonable for a home sleep test where the patient is administering this themselves. The watch pat test, which I know Dr. Davis and I have talked about in the past, is pretty straightforward. The big thing that's happening right now is the patient gets the equipment from an LPN, let's say, and then our current rule says that we can punish the physician that reads that test if it's not done correctly. But these are being done by the thousands, if not tens of thousands around the state right now. And so I don't really think the doctor that reads them should be punished. I've been asked to read them. I hadn't read any yet because I didn't want to do anything that wasn't in line with our rules, but we need a distinction. An in-lab study is a different animal than a home sleep test, in my opinion. What do y'all think?
I think that there's no lack of access to data for patients. And they have wearables, they have apps, they have a million ways that without any physician intervention, they can get all kinds of data on their saturations, their sleep, whatever. I mean, there's a lot of that out there. I think what happens is we have to be careful when we cross that line and we provide that same data, but it's a physician ordered test. And I think that we have to realize that there's an overlay that somebody has got to look and say, is this the right type of patient to have this kind of tests? So do they have contraindications to home testing? We have to have somebody that's familiar with the particular home testing equipment. Is it adequate? I mean, are they trying to do things that they can't do with the data that they're collecting? And then somebody that can actually apply it to what the patient needs. Because my experience with this, you know, we call it the drop ship studies, is that a lot of them, the patient gets data and it says they have mild sleep apnea and they get a CPAP, but when you looked at it, it was artifact and they didn't have sleep apnea. When you repeat the test, it was, you know, bad resources and put the patient through a lot. Or they didn't sleep at all during the sleep test, but nobody asked them, did you sleep when you had the equipment on? And so they were awake all night. And so they're told you don't have any sleep apnea. So I think the biggest problem, we don't have a lack of access to testing. We have a lack of access to clinicians. So maybe we should be drop shipping physicians out to these patient houses, because that's the problem. We're not getting clinicians to apply and look at this and treat the patients. That's my soapbox for the day.
What do you think, Dr. Bordelon? I agree with everything Dr. Davis is saying. I mean, I think physician oversight is important. One of the things that our rule is really strict on is that the equipment has to be handed to them by a sleep tech or respiratory therapist. And that I do that, but probably the majority of the ones, even in doctors' offices, are getting handed out are not being handed by a respiratory therapist. So That's the part that I think we could be a little looser on as long as we have physician oversight. But I'm curious, Dr. Bordelon, what do you think?
What we've had trouble with is that patients that get the test are not adequately informed of the results, the significance of the test. And then somebody may say, oh, here's your machine, and not really tell them much more than that. I feel like the patient is the one that's suffering. You know, I know Matt Abraham, and I contacted him, and he's got this process that he does. The concern I have is that a huge percentage of our population don't have access to adequate internet, and so they may not be able to follow up through his company, and then they're showing up maybe at somebody's office or maybe just giving up and not getting therapy. So I'm worried more about what's happening to the patient.
Is there a way for the equipment to be distributed? Let's even say if we're dealing with a doctor's office by, say, an LPN or someone like that, and then we put some language in there that there has to be follow-up with we could either say follow-up with a sleep physician if there's enough of us, or follow-up with either a sleep physician or the ordering physician in office to go over results. I don't know. I'm just thinking out loud.
I don't think it has to be a sleep physician. I think just somebody to go over the results was the minimum. I know that there's a company that's in Opelousas now, and they contracted with a group of nurse practitioners, and they are giving results out. At least they're informing the patients of what's there. But I think there's just a lot of people that are not getting serviced, and we need to stress that they need to have follow-up.
Dr. Davis, do you think if we stress that they need to have follow-up, that we could allow the equipment to be distributed by someone other than a sleep tech or respiratory therapist?
Well, I think, there's a lot of ways to put a safety net in for patients. And I'm with you, Kyle. A lot of this new home sleep testing equipment is pretty straightforward. You can train somebody in your office to do it pretty quickly. What you lose is, I will tell you, the large majority of our patients that come in to get set up for home tests, they're asking a lot of questions. They get a lot of education at the time of setup. And you're missing that. Is that irreplaceable? No. But I'm thinking out loud as well. What if, ethically, as board certified sleep physicians, we should on some level have responsibility that if we're going to get paid for an interpretation on a study, that we know that there's a system in place to get follow-up care. So that takes out the I'm gonna do an interp on 100 home sleep tests and never care what happens to those patients or see them. So that's the other process. We can regulate what our sleep physicians do. If you're doing an interpretation, do we have some responsibility that they get follow-up? I don't know. I'm just throwing it out there.
And we might need to do a meeting kind of like that other one we're setting up with the three of us doctors to nail this down and bring it back to the committee, because this is probably an important thing to decide, because most tests are being done at home now, and there's a lot of them, and we need to clarify this, I think.
Yeah.
Well, when just Olivia sets up the meeting for Dr. Davis and Kyle and I, we can include Dr. Joe, and we can all get together and do this. That gives us 3 items on the agenda already.
Okay.
A lot of stuff going on.
Dr. Van, did you say that there's a public comment?
There are no public comments at this time.
There is from that tech Paralewin.
I'm looking at the public comment email. We have received none. If you've got one, please read it. It's not on my email list.
Let's see. Okay, I just put it in the chat. You see it?
I'm looking at public comment. I
I
don't
just
see
put it
any.
in the chat.
It's in the chat.
I just put it in the chat. You can see it.
Okay.
I sent it to you.
Okay, so how did it get to us? If it
A
didn't-
public comment.
Comment. You sent it here. That's the comment.
Why is mine not showing it?
I'm not sure.
I don't know. Let me read it in. I apologize. Somehow it didn't get to my list of public comments, but I'll make sure I read it. Sorry, I was in the attendance at this meeting, but I'm muted. I'm requesting to add RT or Poly Sleep Tech license that these professionals should be allowed to activate and adjust Inspire post-operatively. The public should be protected by allowing only the individuals that are schooled, trained, and Inspire and trained to do the activation, settings, and adjustments and follow-ups. Kindly submitted TAC Parallon, RRT, RPSGT.
I think that's what we are kind of already had addressed.
Yeah, I think that's where we're trying to go.
Yeah, I mean, that's definitely where we're going, whether we use that with the activation. I think the activation is best done by the surgeon, but settings, adjustments, and especially during sleep studies, clearly, I think, is a good direction.
Well, again, we will take his comment to heart. We'll put it in as part of the agenda for when the three of us get together, or four of us get together, and we'll make it happen. Well, I think he's got some points that we've already talked about, and I think it's reasonable.
And it'll be recorded as part of the minutes of this meeting as well.
Yes.
I have a question. When the procedures are being done, you have the company rep comes in. How are those approved by the hospital for them to be in the surgery suite?
Yes. They do them, we're in our community, they do them in the hospital and in Ochsner's outpatient surgery. And there's a specific rep that is assigned to our area that's there for all the procedures.
With the hospital credentials, those people to go in the operating room.
So and besides the pacemaker reps and I guess orthopedic reps that kind of come under the same umbrella.
But yeah, most hospitals give them special credentials to do that.
Do we have any other items we need to address?
Let me pull up the agenda again for everybody, but I don't think there's anything else on the agenda.
So next, under old business for next time, we'll have the revisions to rules and regs, the polysomnography course, home studies, and anything else. Okay.
All right.
And when do we need to meet again?
I would say you probably want to meet again sometime right after January. And we'll have the results of the interim meeting that the three docs and I have with Ms. Wilton. And we can report that. And if the board advisory committee recommends it, we'll take it to the January meeting of the board to get approved by the board for rule implementation.
Okay. So mid-January or Friday? Works for everybody?
Sounds great.
Yes, sir.
Hang on, let me look at the schedule to see when our meeting is, but we need to get this a little ahead of time. Hold on one second. Let me see. Board meetings, the January meeting is going to be January 23rd and 24th, that's 23. It's gonna be the 22nd and 23rd.
You want to take your 2 putts back to back, or?
No, hang on 1 second. I'm just trying to make sure. We'd like to get this. I'd like to get it before we have to close the agenda if I possibly could. So if we did it Friday, we're gonna close the, let's see, we're gonna close the agenda when? Oh, man. So let's see. We'll be closing the agenda on the 8th, so if we could do it Friday, the 5th in January, that'd be great. That's our advisory committee meeting for Friday, the 5th of January.
11 a.m. Is everybody okay with that?
I've got to be in some training at the hospital until noon that they tell me I can't get out of. It's 8 to noon. So I don't know if we could do it at like 1, or if you want to do it.
1's okay with me.
One's okay
Laura?
with me. I'm okay with it.
Okay. Christine, Joshua,
I'm good with that. I'm fine with that, you say.
Kylie,
Sorry, I thought I was unmuted. I'm free.
okay. So January the 5th at 1 p.m.
Yes, sir.
All right. Okay. And then the small group,
When y'all want to meet, I'll make myself available. The only day I really have to be honest with you, I can't think I could do it unless you did it late in the afternoon, would be the 24th of this month. My wife's having surgery that morning. I'll be free that later that afternoon if you do it late in the afternoon.
Would a week from today work for y'all, same time or no?
Let's
I think
see.
a
Make
week
sure.
from today's LASM.
November 3rd, I can't do, but I could do the 10th. That's Veterans Day. I don't know
Unless
if
we want to do it
y'all-
Thursday.
I have something that week.
November,
How about the following?
November 17th, maybe?
November 17th is fine with me.
No, Dr. Claudia, November 17th,
Hang on, let me see.
you have a meeting.
No, we
that-
got an advisory committee meeting already that day. I'm
Yeah,
sorry.
we're gonna need to push it, we're gonna need to push it after November 20th for sure.
What about November 30th?
Well, the only issue I have people hooked up like 3 months in advance, so Thursdays are harder. I don't know if y'all could do Friday, the next day, December 1st, possibly.
Friday, December 1st?
Good for me.
Wait a minute, hold on a minute. I must be in the wrong year. Because mine says December 2023 is the 1st of November is a Monday.
Just, you talking December 1st, Dr.
First of December.
Okay, December 1st
Yeah.
is a Monday.
I got a Friday, is that right?
It's a Friday.
Friday too.
Friday, yeah.
God, this calendar must be crazy.
We are available December 1st. Did you want to do like a 11 or a 1?
Either is fine with me, whichever y'all prefer.
Dr. Davis, does
We
11,
want 11, it may take a little while to hash it out.
want to do 11?
Yeah.
Dr. Bordelon, it's good for you on
I'll
December?
work, yeah.
Okay. And so it's just the 3 of you, correct? The doctors?
Yeah,
Yeah.
So December 1st at 11 a.m. I will send out those invites for this meeting as well.
Okay.
Thank you.
You're welcome.
And me too, right?
Yes.
yes,
I'll
Ms.
come
Wilton, you too.
as
Yeah.
well. Yeah, I'll send them out today.
Good deal. I think is that a wrap?
Unless y'all got any other business you want to entertain?
So when we meet on December 1st and we get something preliminary, can we get it out to all the board members so that they can start, reviewing it and stuff before we present it?
We'll send it out as part of the agenda that we post on the website. We could post it
Good.
earlier than the agenda on the cloud share for everybody to see.
Yeah, it's just you can't have, it's just individually to review it. You can't have discussions outside the public meeting among yourselves, if that makes sense.
Okay. Yeah, I want to make sure that everybody gets some input here because these
Yeah, absolutely.
are big things.
Dr. Bordelon, do we have to call to adjourn?
Oh, yeah, I move we adjourn.
Second.
Thank you all very much for the time and attention to these matters.
Okay.
Thank you.
All right.
Have a good weekend. Bye, everybody.